Erectile dysfunction, diagnostics and treatment. We don't treat the disease, we treat the patient. So here we have our patient, he's 45-year-old, safety inspector in the happy-go-lucky toy factory, passionate fisherman, father of 3, and he's experiencing erectile dysfunction problems. So he doesn't have erection rigid enough for satisfying intercourse, and if the erection appears, it usually disappears during the intercourse. He's experiencing these problems for past 6 months. The first step, if we have a patient with ED, we ask about sexual history. How was his previous sex life? How is the present sex life? How many sexual partners did he have before? What's his sexual orientation, sexual desires, frequency of nighttime or morning erections? How is the ability to achieve erection? What's the characteristics of the semen? If there is any painful ejaculation, problem to achieve ejaculation, achieve orgasm. And how is his total satisfaction with his sex life? If we want to evaluate and somehow make the problems of the patient objective, we can always use validated questionnaires. So one of the questionnaires is E5. So it's a short questionnaire to get the idea how bad the problems of the patient objectively are. So you can ask how hard is it to get the erection, maintain erection, how many times does it disappear during the intercourse, and you can get the score that gives you the idea. Another kind of validated questionnaire is erection hardness scale. We can ask the patient how hard is the erection when it is rigid, from 1 to 4, or we can actually describe the erection as 1 soft as tofu, 4 hard as a cucumber, and we again get the idea how bad the problem is. Then we continue with the standard medical history, and we're searching for typical etiologies of the erectile dysfunction. So if he's using some recreational drugs, if he's smoking, if he's lacking physical exercise, if he's obese, has some cardiovascular problem, if we're considering vasculogenic etiology of erectile dysfunction. If we're considering neurogenic dysfunction, then we ask about, let's say, pelvic surgery. If he had some major surgery to the pelvis or to the retroperitoneum that could do any damage to the innervation of the penis. We can ask about diabetes causing neurogenic dysfunction. Ask about sclerosis multiplex. Ask about some spinal cord injury, or we can focus on for hormonal dysfunctions. So again, diabetes, metabolic syndrome, hypogonadism as the etiology of the erectile dysfunction, or even hyperprolactinemia causing the erectile dysfunction by secondary hypogonadism. Psychogenic dysfunction used to be a very common diagnosis before. Before it was considered 80% of the erectile dysfunction being psychogenic. Now we know it's the other way around, that in 80% of the patients we actually find an organic etiology of the disease. And then ask about trauma. If there was any penile trauma, penile fracture, pelvic fracture that could cause the damage to the vessels or to the nerves leading to the penis. From the pharmacology point of view, we ask about drugs used that could induce erectile dysfunction. We know that some of the antihypertensive can cause, like beta blockers in higher doses, antidepressants, antipsychotics, antiandrogens, of course, in the treatment of prostate cancer, and also recreational drugs, as I mentioned, alcohol, heroin, cocaine, marijuana. Next step is, of course, physical examination. So we do the standard physical examination like in any urological patient, but then we continue to focus on certain etiologies. We're looking for Peyronie's disease. If there is some curvature and induration of the penis causing the erectile dysfunction, hypospadia, epispadia, micropenis causing the problem of satisfactory intercourse, phimosis, if there is a scarring of the prepucium There might be pain during the erection, painful intercourse causing their ED as well. Penile cancer, infiltration of the glands. BPH is often connected with ED as well, and signs of hypogonadism. What's very, very important, because most of the EDs are actually vascular etiology, you should measure the blood pressure. I would like to stress that out. I mean, urologists are not that used to measure blood pressure, but you can save the patient's life. You can have severe hypertension, and that's the cause of the vascular damage, and that's the cause of the ED he's experiencing. So what should be the step one treatment? And your patient usually don't want to hear it, is to identify and remove the reversible factors you might find. Usually obesity, hypertension, diabetes. Those are the diseases that has to be identified and treated very often by lifestyle changes, not only by medication. And your patient, when he's coming to your clinic, usually expecting to treat him within one session and not ask him to lose weight, start to move, have less stress, eat healthy. So what are the treatment options of erectile dysfunction? So the causative treatment is a treatment of the etiology. The symptomatic treatment is what we as urologists can offer to the patient, and it's usually, as a first-line treatment, is a treatment with Viagra, with PDE5 inhibitors, or vacuum erection devices, shockwave therapy, intraurethral application of prostaglandin, or psychosexual therapy. So we have currently 4 PDE5 inhibitors on the market. So what's the difference? So the number one inhibitor is sildenafil Viagra. That was the first PDE5 inhibitor introduced to the market as a treatment of erectile dysfunctions. So Viagra is taken usually 1 hour prior to the sexual intercourse, and the effect lasts up to 6 to 8 hours. Tadalafil lasts up to 2 hours to 3 hours to start working, but the effects can last up to 30 hours. So if you take it in the morning, you have the full day before you can have your sexual intercourse. Vardenafil, the pharmacodynamics are similar to sildenafil. And navanafil, that's the last molecule we have on the market. The advantage is that it should be effective within 30 minutes after using the tablet, the pill, and the effect should last up to 24 hours. So seems to be ideal, but unfortunately we experience that not effective in all the patients. So it's up to the patient to choose which PDE5 inhibitor is best for him. There is no direct comparison study. We cannot tell which one is the best. It's usually patients should try what's the best pharmacodynamics for him, what's the best effective molecule. Of course, there are some adverse events of using PDE5 inhibitor. It's a very safe treatment, although some patients are experiencing headache after using the pill, flushing, and nasal congestion. There are some rather rare complications or adverse events like abnormal vision. Some patients are describing pinkish vision after using the pill. How about the drug interactions? Many of our patients, when they come to our clinic and you ask them if they tried some of the medication, they say, no, I was too afraid because I'm using antihypertensive drugs. The only serious interaction that's described, is interaction with using nitroglycerin before or amyl nitrates before using the Viagra or after using the Viagra. So especially we have to educate the patient about using nitroglycerin if it's a cardiac. They cannot use both because of the very high risk of serious unpredictable blood pressure fall. And if we have a patient who used PDE5 inhibitor and is experiencing chest pain, and we should give him nitroglycerin to ease the pain, we should know that we cannot administer nitroglycerin 24 hours after using sildenafil and vardenafil, 48 hours in case of tadalafil, and 12 hours after using vanafil. So the next treatment option from the first line is vacuum erection devices. So it's a passive engorgement of the corpora together with constriction ring based on the located at the base of the penis to retain blood inside the corpora. The erection is usually rigid enough for the intercourse, and it works in up to 90% of the patient. The problem usually is the aesthetics of the penis. Because of the passive engorgement, there is a venous blood, there is a bluish discoloration of the penis, there might be even petechia on the skin of the penis or bruises from the constriction ring, and of course, because there is a constriction ring placed on the base of the penis, there is anejaculation. So not many patients continue using this treatment method. Another option is low-intensity shockwave treatment. That seems to be a very nice option. The idea is to create neovascularization to the corpora cavernosa, therefore in this way to improve the erectile function. And the effect, according to the studies we have, is very good. Unfortunately, it doesn't last for very long, so the patient has to expect to repeat the method and to repeat the visits, repeat the application. So the second line treatment is of course more invasive. So if we have a patient that don't respond to the first line, we can continue to the second line, which would be intracavernosa application of the prostaglandin or alprostadil. Success rate is very high. If the veno-occlusive mechanism works, it works in up to 85% of the patients, and it requires some manual dexterity. Of course, the patient is very frightened at the first time if you tell him he'll have to insert a needle into his penis, but eventually many patients learn how to do it. The risk of priapism exists. It's definitely higher than in PDE5 inhibitors, but if we use prostaglandin and not the combination therapy with different chemicals, it's very, very low. So here you can see the application when you insert the needle to the corpora cavernosa and apply the prostaglandin inside. We use only unilateral application because there is a connection in between the corpora cavernosa. So the application is usually 5 to 40 micrograms according to the reaction of the erectile tissue, and the erection comes within 5 to 15 minutes. And according to the dose we apply, it can last up to 60 minutes and more. Usually it's up to the patient to find his ideal dose to have an erection rigid enough, long enough, but not too long and too painful. What are the possible complications? 50% of the patients describe a penile pain after application in 11% of the applications. Some patients describe prolonged erection that causing them discomfort. In 1% there's priapism, and in 2% there might be fibrosis in the area we used to apply the chemical. What's very important, even though the effectivity is very high and the patients are very satisfied at the beginning of the treatment, usually around 50% discontinue the treatment within the first 2 to 3 months. Because of the complications, because of the invasivity of the treatment, because it's not natural to apply the syringe into your penis before the intercourse. So what is the third line treatment? The third line treatment is prosthesis. We have currently 2 types of prosthesis on the market. It's inflatable and semi-rigid. Here on the picture is an inflatable prosthesis where you have 2 cones that are inserted into the penis instead of the cavernous tissue. So as I mentioned, it's an irreversible procedure. Before the insertion, you have to destroy the cavernous tissue. So you use dilators to destroy the tissue and insert 1 cone to one corpora cavernosa and another one to the other side. Those are connected to the pump that's placed in the scrotum and the balloon with the liquid filling that's placed in the abdominal cavity. So if the patient wants to have the erection, he compresses the pump in the scrotum for several times, and the liquid goes from the balloon into the cones inside the inside the penis and cause a rigid erection. After sexual intercourse, when he wants to put his penis back to the flaccid state, he needs to compress the valve and compress the penis to deflate the cones, and the liquid goes back into the balloon inside the abdominal cavity. The, let's say, cheaper version and more simple version of the prosthesis, the semi-rigid prosthesis, but as you can see, it's semi-rigid. So the patient eventually will have a permanent erection. The penis will be permanently in erection, and he can just change the shape. So during the intercourse, he can straighten the penis, and during the daily life, he has to bend the penis for better cosmetic effect. The satisfaction rate of the inflatable prosthesis is actually very, very high, both from the patient side and from the partner side. So it's up to 100% of the patients are satisfied with the effect after the implantation of the inflatable prosthesis. And as any other implant, it can have its complications. So the number one is, of course, infection. What you can see is actually for an implant quite low, 2 to 3% of the patients are experiencing some infectious complications. Or risk of mechanical failure because of quite a complicated systems, but as again you can see, after 5 years is only up to 5% are experiencing some mechanical problems with the inflatable prosthesis. And if we want to reduce the risk of infection complications, we can implant so-called antibiotic-coated implants. So there is a coating of antibiotic on the surface, and this can decrease the complications up to 1 to 2%. So at the end of the day, any line of the treatment we choose, what's very important is a happy patient with a satisfactory sex life.